Eaglemount Academy is a private Christian-based institution located in White House Estate along the Nakuru-Solai Road in Nakuru County. We believe in prayer, smart work, discipline, and excellence. We mentor, nurture, and transform our learners into responsible young people in the community. In Eaglemount Academy, we offer education on a holistic level from daycare, ECE, lower primary, upper primary, up to junior secondary. The teachers are highly qualified and competent and give the parental love needed to the learners. In Eaglemount Academy, we offer computer classes and also integrate ICT in our learning in order to cope with the modern day technology. We offer French as a foreign language in order to help our learners link with other learners across the globe. We have invested in co-curricular activities in order to help our learners to be physically and mentally fit. We offer a variety of sporting activities such as football, volleyball, netball, swimming, and chess. We have club activities such as scouting, music and drama, wildlife, guidance and counseling, and 4K, which offer the learners with an opportunity to think critically and gain necessary skills for day-to-day living. Safety being our priority, our classes are spacious, well ventilated, and have adequate lighting. Nutrition being important for learning, we offer a highly nutritious, healthy, and balanced diet. Eaglemount Academy, we are pride. Persistent, responsible, independent, dedicated to excellence. Our slogan is, we are the best. For more information, you can contact the office through 0112 403750 or 0743948636 or email us on imaknax@gmail.com.
Are you a bishop, a pastor, or a church leader looking for a reliable, popular, and affordable TV station to air your sermons? Search no more. We have some good news for you. Tumaini TV is offering you the best package to broadcast your church services and sermons. Call us today and join us in bringing hope to the nations. Our lines are open. You can reach us on 0736 991 958 or 011 0100 258 or email us on info@tumainitv.co.ke. Tumaini TV, bringing hope to the nations.
Today we are going to talk about a very important topic, which is infertility, and infertility affects millions of people globally. And with me, I have my fellow panelists. They can start by introducing themselves. I'll start with my far end.
Thank you, Collins. Once again, I'm Dr. Kengo Salvan. It's always a pleasure to be in this show. We've had this reproductive talk show for quite a while now. Dr. Kengo, I'm located at Nakuru currently. I'm also the CEO of Vimeo CBO, Victoria Medics Empowerment Organization. It's an organization that deals with community health promotion, mentorship, and generally creating awareness in the community about matters health. Santi sana.
My name is Alan Rono. I'm a senior medical student at Egerton University and also a beneficiary of Nyaluk Foundation. I take a lot of passion and confidence on the issues of obstetric and gynecology, and also with a lot of curiosity around matters dealing with infertility. Yeah.
And this show is called Afya Yetu, and it's normally sponsored by Nyaluk Foundation. And we'd love to hear from you. And if you want to be part of this conversation, kindly reach us through 0110 100 258, or you can also reach us through all our social media platform. So today we are going to talk about infertility, and we'll just start by introduction from Dr. Salvan. Maybe you can tell us what is infertility and who is affected the most. You know, because infertility is a disease of the two. It's only the only disease. Ni ugonjwa peke yake mpaka umkwe wawili ndio upate. So it affects the two. So daktari.
Asante sana Collins. Actually kuna gonjwa zingine tunaweza pata tukiwa we have to be wawili ndo tupate. We talked about STIs the other day.
Yeah.
We delved into them. Anyway, that is a by the way. Infertility is a controversial topic, hotly contested, and is one that many people want to delve in, really. How I wish our viewers today will be more involved, more engaging, and more interactive as we delve into this discussion. Let me start with the definition of infertility. Infertility is the failure to conceive after having unprotected, successful coitus. And I'm stressing these words. You'll ask me later what I mean by successful coitus. Because somebody might wonder, do you have successful sex and unsuccessful sex? So it's failure to conceive.
Yes.
After having unprotected coitus. Coitus is sex. Without conception. Are we together?
Yeah.
Without conception for a period of 1 year. And within that 1 year, you have to have that sex frequently in a week. You'll ask me later what I mean by frequently in a week. Because how frequent is frequent?
Yeah.
Yes.
How frequent can you have sex in a week? Frequently in a week, within 1 year, for women less than 35 years old.
And what about women who are more than 35?
For women who are more than 35 years old, the time frame reduces.
Yeah.
The definition now goes to 6 months. Now, failure to conceive after having frequent unprotected sex without conception for 6 months. That is for women who are more than 35 years old.
Yeah.
But it's for 1 year for women who are less than 35 years old.
Okay.
I know that from the definition alone, there are a lot of things to talk about.
Maybe Alan can expound on the age factor, so that maybe if somebody is watching from home, kama kuna mtu mwenye anatazama TV kutoka nyumbani, anaweza elewa which category ana fall na what are the factors that maybe might lead the person to be categorized as maybe according to the age factor.
So according to the age factor, as per the definition that Dr. Salvan has given us, so for females above the age of 35, the rate of infertility increases, and the reason behind this is due to the eggs, and the eggs, there is quantity, then there is quality, and there's also the structural aspect of the female reproductive system. So in quantity, since every lady every month they shed an egg, so that means the quantity of the eggs, because women, once they are born into this world, they already have a set of eggs which are gonna, some of them are gonna be productive, some not. Yeah, so with age, once you shed the eggs that you shed earlier on are the more productive eggs. So once you shed all that and you're in the age of 35 and above, most of the eggs that are remaining, most of them are not going to be productive enough. So that's the aspect of reduced eggs and also reduced egg quality. And then also structural aspects. As you grow, there are things that may come with age, such as fibroids, such as polyps, such as scars. So this also may impede the fertility process. So I think.
So I think
Just to add something.
yeah.
Very true. I think what Alana said just in summary is the older you get for ladies, the wearier or the more tired the eggs get, in simple terms.
Yeah.
The earlier the better. So the assumption is if you get older, if you try having a baby, within that short time, we can come to that conclusion more rapidly that probably you have a problem.
That
as
is
compared to a younger lady whereby you can give them a longer time frame.
So, Daktari, now if you are saying the older you get, the lesser the chances you have for having a baby, or you risk developing infertility. Somebody out there might ask, now what's the right age? So maybe you can tell us what's the right age for somebody to get pregnant.
The right age for pregnancy, actually we touched on this before. I think sometimes back we had this discussion.
Yeah.
When we talked about, physiologically speaking, when one is able to withstand or one is able to reproduce physiologically, that is past adolescent, when they're physiologically mature, the eggs are ready, and even the anatomical structures are ready to withstand a pregnancy. That is within the adolescent age. You're talking 13, 14 for girls, actually from 12. But legally speaking, whereby legally you have to incorporate other aspects like the psychological maturity, you have to consider the financial capability, because you don't want you to bring a child into this world to suffer, literally. So legally speaking, literally you're talking over 18. And for ladies, we say, because just as Alan has said, you have about over 1 million eggs by the time a lady is born into this world. These eggs gradually increase all the way to adolescent. And when you reach your adolescence, the adolescent period, they actually hit the maximum. The gravid follicles, I think, are at over 20 million.
Yes, 20 million.
So really at this age, we say, if you can do it between 20 to 30, let's not get to 35, that is the best age that, scientifically speaking, we say is the best for reproduction. That is talking of quantity and quality of eggs. But I have to stress that we don't rule out that past 35, we declare you that you're going to be infertile, or we declare you that your baby is going to have difficulties. What we say is it's likely to be more difficult, it's likely to result into more complications, but it doesn't rule out that you cannot get pregnant and have a normal baby. I think I have to make that clear.
Okay. And now the issues where you get that maybe somebody have never gotten pregnant, or somebody have gotten pregnant and now they cannot get pregnant. So maybe, Alano, you can tell us, maybe, do we have different types of infertilities?
Yeah, sure. So infertility, there are two types of infertility. One is primary infertility. So primary infertility is the type of infertility where you've conceived once, and then after that it becomes once or twice, then after that it becomes difficult to conceive again. And on the other type of fertility is secondary fertility, where you are unable to conceive. primary infertility is where you're unable to conceive at all. Then secondary infertility is where infertility comes after conception. So conception of the first or the second, the third, then after that you're unable to conceive upon trial to conceive. Yeah, so
And also, you get that in infertility, maybe you've gotten pregnant with, like for example, I've once came across a case where somebody told me that she was married for like around 5 years and she couldn't conceive with that guy. And when they broke up because of infertility issues, she went and conceived with another man, and immediately also that man got another lady and they conceived almost immediately. So, Dr. Salvan, how would you explain that you are fertile, but you are with this man and you cannot conceive? And when you get out of that relationship, you get that you are conceiving. Is there maybe antigen factors, or somebody can reject somebody's sperms or something like that?
Asante sana Collins. Actually, before I answer this, I want to build on the past question that you just asked me, and actually bounce it back to you after I'm done with this. We say, does the females age, their eggs wear out, right?
Yeah.
Most people are more interested. They want to know what happens to the males when they grow old. Do their sperms also lose it in terms of quantity and quality, as we say? And for men, do we have the age limit that we are talking about? Or is it capped at a certain age? Now, back to your question. You said we had a scenario whereby a couple had, with their first partner, they managed to get pregnant, but when they didn't manage to get pregnant, but when they moved on to the next partner, apparently they were able to get pregnant. I think that brings us to another major subtopic of the day that we'll delve on: the male infertility factor and the female infertility factor. Infertility is broad and requires thorough, meticulous, and comprehensive medical evaluation for both partners. I have to stress, for both partners. I mean, there have been many cases whereby most people, especially males, have this prejudice that when infertility issue raises up in a family, it's certainly the female gender. So really, the infertility requires thorough evaluation for both males and females whenever it rises up in a family. The obvious conclusion in that case can be, if the female got from one man to another and he got pregnant with the other and he was not able to do with this other one, the obvious assumption that is in the layman's side, without doing any other test, further examinations and blah blah, the obvious assumption is probably you had a problem with the first man. But I know that the man will never sema mimi siwezi kuwa na, kwa familia yangu sisi hatujawahi kuwa na shida kama hiyo.
Hatujawahi kuwa infertile.
Hatujawahi kuwa infertile.
And by the way, Daktari, why is it that women are always blamed?
Really, I think it all stems from the cultural perspective, where it stems from our most African traditional cultures did believe that males had some sort of a superiority over the female gender. And with this, the males always had that stereotypical belief that males cannot have the fertility problem. Yunamleta kwetu, yenda anakuja kwetu, yendo lazima amekuja na hiyo shida.
Yeah.
And because our African setup really was more aligned towards polygamy, the thinking then was that in case infertility comes up, it's always the female. And if it's not possible with that one female, you can always add another, and another. But infertility in our traditional setup, it's a more wide topic that we can talk about later.
Yes.
Because back then, again, even when the man could not do it, apparently they had some structures, though they were certainly allowed, where even the brother or even some random guy in the village will come and sire for this guy just to cover up his shame. So apparently to them, infertility on the male side was untenable, it was unimaginable, and in cases where it was clearly prevalent or where they knew that so and so cannot do this, they even slid in ways to cover for it so that the man could not be embarrassed.
Like actually, I know of a tribe in Kenya where if a woman, if a man is infertile, the brother comes in for him, and it happens a lot. The issue now comes when maybe the woman is the one who is now infertile, because if you're a lady and you're infertile, your sister cannot come cover for you. And what you are saying actually is true, Daktari. And maybe just
Doc, what you're saying, even to, if I think clearly, I think in the Luo traditions back then, if the first wife, the Mikai, if the Mikai could not sire or bear a child, I think they used to bring the younger sisters. It was not even up to the man. It was up to the woman to bring a woman of her choice that she can tolerate in this home. And I think that there are many cases. I have even friends whom I know, like the first wife. Is the sister to the man.
What I meant by that was, like, for me, like, for example, if I cannot sire a baby, my brother will come for me secretively. So I won't bear that, maybe, I would call it, people call it shame or something, or that stigma to the society that I cannot sire. Because when I'll be introducing them, I'll be introducing them as my children. But now, if a lady cannot produce, cannot give birth, and maybe the sister comes in for her, now everybody will know that those children are not hers, but her sisters. She cannot give birth. Because we know there's a lot of stigma around it. Maybe Alano can tell us maybe a bit of Kale aspects and maybe what you've had.
I think heavily, again, it's just a repetition of what Doc has said. For African culture, the male, he's viewed as a strong aspect, yeah? So most of the negative aspects, such as infertility, it's not something to be shown out there. So that's why you have the covering up of a brother or maybe someone in the community who comes in. So for the male aspect, if I'm in my culture, Kalenjin, from what I have heard, yeah, is that if a man is unable to sire, the same thing, a brother or a friend, a close relative can come in, give sire for the man, and then it's kept totally under the blanket. Nobody will ever know. So there's that aspect. Now you get your child and you call him yours, and yet he's your brother's child.
And as we proceed, maybe to our viewers out there, maybe if you're joining us for the first time, this is Tumaini TV. The show is called Afya Yetu, and it's sponsored by Nyaluk Foundation. And if you have any question, any concern, kindly reach us through 001 100 258, or you can also text us through all our social media platform, which is Tumaini TV, and also you can reach us through other platforms like Vimeo and Nyaluk Foundation social media platform, so that we can have this conversation going. And Daktari, maybe if we can just dwell a bit deeper into this conversation, are there early signs of infertility? Like maybe if you are having a certain signs and symptoms, you can know maybe I might be infertile. Dr. Salvan.
Asante sana Collins. But nimekumbuka tu kujibu swali yangu. There's a question I bounced back. There's a question I bounced back on whether sperms do wear out in terms of quality and quantity and
okay, I can take it. Okay. Or maybe Alano
you take it.
Okay,
because it was your question.
So the male fertility factor, or from what I've read, is the male fertility reduces with age, but not as much, because you get that even a 70-year-old man can sire a baby. But the sperms, what normally happens, like the level of testosterone normally reduces. The testosterone is the male hormone which make us who we are and also helps in sperm production. So with age, the sperm production reduces, but not as much as we would say that the ladies, the whole eggs get depleted. And also with age, you get that male develops issues with their erections. You get that they don't have that strong erection, and if I might use that word, some deliver before arrival, so premature ejaculation. And also these factors also contributes towards infertility. Daktari, I don't know if I've answered your question.
Yes. You've answered my question. Yeah, I actually agree with you. Though you've led me to a point I really wanted to touch on, though you're not reached there. Is erectile dysfunction and infertility the same thing? Does it mean if a man cannot stand, he cannot sire? Kama hawezi simama, hawezi zaa? Na does it mean kama anasimama, basi automatically anaweza zaa?
Yeah. Myths and misconceptions. Yeah. I think hold that thought. We'll get there. And maybe you can tell us a bit, maybe if my body is like this, am I... because, you know, for a reason, there's a reason as why men go for curvy ladies. And I think Alano will tell us more about it. Proceed, Daktari.
This is getting interesting. Okay. Let me touch on the early signs that might make you suspect that this guy or the lady may or might have infertility issues. As you say, our guy, we will touch on the curvy ladies later. Thank God you've excused me from that. So, infertility encompasses 3 key components. You have the hormonal component of infertility. You have the higher centers of infertility. Then now you have the, okay, let me call them in quotes, the lower centers, whereby I mean now the genital organs that play a role. Generally, in your physiology, you used to call it the HPO axis, the hypothalamus pituitary ovarian axis. That is for the ladies. Though I remember Dr. Seyo used to be very livid when you meet the endometrial part. So for him, it was HPOE.
Yeah,
okay. Okay. So there's a whole that it always starts from the mind, as it said. There's a famous phrase that goes that sex starts in the mind. If the mind is put off, there's nowhere we're going. If you don't turn me on mentally, you won't raise me up down there. In the mind, you have the organ called the hypothalamus, which is very important. We say it's the master endocrine organ. The hypothalamus takes control of almost a very big percentage of our hormonal production in the body. For example, when it comes to our sexual organs, from the hypothalamus, we have the production of the gonadotropic hormones. Gonadotropic releasing hormones that goes the pituitary, whereby they stimulate the pituitary to release now the gonadotropins. From the pituitary now, after the gonadotropins are released, they go all the way down to our genital organs. That is our testes, ovaries for ladies, the endometrium, where they stimulate them now to produce the key hormones of fertility that we're talking about, especially for the males. For the males, we have the so-called testosterone. It's called the male hormone. Ukitaja testosterone, ujama, it's associated with masculinity generally. It is responsible for spermatogenesis, that is sperm production. It is responsible for development of our sexual organs right from childhood, not even childhood, right from in utero. That is from intrauterine life. Actually, if you remember your embryology well, it is rather the presence or the absence of the Y chromosome, that is testosterone, that will determine whether you are a lady or a man. The presence of it makes you a man. The absence of it makes you a lady. That is very early in the embryological process. So, when you have all that axis, a defect in that pathway can lead to infertility. When you have a problem in the hypothalamus, what might cause a problem in the hypothalamus? You might have tumors, hypothalamic tumors. You might have diseases, generally brain tumors that cannot literally affect specifically the hypothalamus, but can compress the brain mass literally, affecting the hypothalamus directly. You can also have factors that affect the anterior pituitary. Still, you might have tumors, you might have infections, you might have some systemic diseases still that might end up affecting our anterior pituitary. You remember what we call Sheehan syndrome? Yes, whereby women during childbearing, they bleed too much. That is after delivery, what we call PPH, postpartum hemorrhage. And when that bleeding gets so much, it might actually end up affecting your anterior pituitary, whereby we get into shock. Shock, the anterior pituitary is deprived of blood supply. When that happens, now you start getting necrosis of the anterior pituitary, what we call Sheehan syndrome. And when that is shut down, the anterior pituitary, we have a whole array of problems. That is from our thyroid, that is on our thyroid, thyroid hormones, adrenal, sexual organs. But now let's stick to the infertility part. So when you have a defect in the hormonal pathway, just as I've said, from hypothalamus, pituitary, we might likely end up with a fertility issue. Let's go down to our genital organs. When you have a problem down there in the genital area, and by problem in the genital area, I mean it may come from lack of the hormonal stimulation that has come from up there, that has led to the genital organs not being well developed, underdeveloped, malformed, or just developed but not to the full extent. So when you have a problem in the genital area still, that might come from the development, or might still come from an injury, might still come from trauma, might still come from an autoimmune disease, what you're talking about, the antibodies, the autoantibodies that can actually start affecting your sperms again. That might come from certain syndromes again that one is born with embryologically. You might have those problems with the genital organs. The genital organs might be, generally in development, might be so okay, but now the outflow tract, we might have a problem there. That is a case whereby you do all the tests, the hormone is okay, pituitary is okay, the testes looks okay, but apparently the sperms are not coming out. Or we have the semen coming out, but there are no sperms. So you start querying, what could be the problem? Do you have an outflow tract problem? Do you have something blocking? Something somewhere? Those outflow tract problems can still lead us to infertility. So, you talked about the early signs that we can see. The early signs most of the times actually come with the syndromes, the embryological syndromes. Something like Klinefelter syndrome. Klinefelter syndrome is whereby in a normal male we have an XY chromosome. But in a Klinefelter syndrome, it's whereby we had some genetical disorientation that led us to having XXY instead of an XY. Literally, a friend of mine used to joke that akona extra X, akona extra umam. So when you have that extra X chromosomes in your XY, a lot of problems comes with it. A lot of problems come with it. And some of them can be seen. These are the males generally. When it comes to development of the secondary sexual characteristics, that is like mandevu,
Deep voice.
iko kwa umbali.
Majama wetu with the smooth chins.
Ndevu iko kwa umbali.
My guys with smooth chins. I'm not trying to say I'm not trying to attack you directly.
Yeah.
But development of the secondary sexual characteristics like the deep voice, the smooth, the pubic hairs, the beards, broadening of the chest, a normal flat chest, unapata ndo watu wako na gynecomastia. Then I don't know, but out of nowhere they usually come out to be so fat again.
And also the height. They're
And
normally
very tall.
they're very tall and weak.
Bones are weak. Yeah.
Yes, generally features of Klinefelter syndrome. Actually, I had a guy in lecture way back who used to joke that if a woman walks into my clinic and they complain of infertility, and I look at the man as sijaona ndevu, 50% of my test nitaanza naye kwanza as the woman awaits. So generally, we don't say that these things directly equate to infertility in a male, but we say that these are some of the signs that may make us probe or examine towards that line when it comes to males. Development of these sexual secondary characteristics. When they lack and infertility issue arises up, they mean a lot. But when they lack and the guy is just fine, jamaa ako tu na smooth chini yake na ako tu sawa, ako na watu wake, it's okay. It's okay. You're not attacking
Maybe
me.
it's maybe we can also say maybe, you know, it's not always that maybe if a guy doesn't have maybe these prominent secondary characteristics of a man that is infertile. I think that one we need to put it out there because we know there are some who are like that, but they are so Aleki, maybe you can now tell us, why do men go for ladies who are curvy?
Again, in the aspect of the mind, yeah. So, but okay, it's about it's about priority. What entices your eyes, yeah. So for men, most men who go for curvy ladies, it's because curvy ladies, the visual aspects, when you look at a curvy lady, it stimulates your mind. So that's the aspect where Salvan was saying it starts from the mind. So when you have this curvy lady, you see in your mind it goes down to the lower aspect, the reproductive organs, and that's how you get these erections and everything because of the visual stimulation. Because the first aspect is visual stimulation, where a man looks at a lady and is attracted, and it's
But I
down.
think what I've read and what I've seen, and I think what is assumed is that the curvier you are, the more fertile you are.
Also,
So, the rule of natural selection.
Yeah.
Yeah, so I think it's normally assumed that the curvier you are, the more fertile you are. I don't know if Dr. Salvan will agree with me.
Thanks, Dr. You said it's a gross assumption.
Yeah.
It's assumed. Yeah. There's another assumption that still touches on the curvy ladies that says that the curvier the lady, the more likely that they will have more intelligent kids.
That's
That's not assumption. That has been proven because we get that in the curves.
I get it actually. Actually, I was going through my Facebook posts. Like, Kitambo. I think nikiwa first year, and I bumped into that in my first semester of med school. I actually posted that in my Facebook posts, explaining why men need to go for curvier ladies, and they're likely to have more intelligent kids because of the omega-3 fats that lie in there and all that. Really, 7 years down the line, I can tell you for a fact, it's said in undertones, really, but it still borders rumors than real scientific evidence. But I know that knowledge is, I know that thing is out there, that notion is out there. But really, I think I can't contextualize it in real scientific evidence, real scientific data. But I know there's an article that talks about that the curvier the lady, the more likelihood of getting intelligent kids. And just to add something, I forgot. On signs or early signs or symptoms that can actually help us predict whether one will be infertile or not. I realize I touched more on
male yeah.
infertility.
Yeah.
And just to touch on female infertility too, the argument still holds what I started with. That is the HPO pathway, right from the mind, all the way to the genital organs, all the way to the outflow tracts. For the females, just the same thing explained. We can have a problem
with the brain,
starting from the brain. That is, we're talking hypothalamus, anterior pituitary. They are the endocrinal problems, the hormonal problems. Then when you come down to the genital organs, for ladies again, we have a lot of factors again to consider. We can have tubal factors, we can have ovarian factors, we can have endometrial factors. Since you can clearly see the female anatomy is more complicated as compared to the male ones.
Yes.
For the men, once you descend there from the outflow tract of our sperms, ikitoka epididymis, ingie kwa the prostatic urethra, seminal vesicles drain hapo, prostatic penile urethra, there you are, umetoka nje. But for the ladies, we come all the way from the ovaries, tunakuja kwa fallopian tubes, tuingie kwa uterus, cervix, all the way to the vagina. So you see, when it comes to the genital organs of ladies, we have an array of tests and examinations that we need to do to rule out and to ascertain the exact cause of infertility. That is, in case we've ascertained that it's at the genital area. Still, just to touch on some early signs or some early symptoms that you can see that majorly arise from endocrinal problems for ladies. It's still the same. For ladies, we have the embryological, the same defects that I talked about that can occur during sexual development. You also have a case whereby the normal lady has an X chromosome.
Yes.
Sindio?
Yes.
So we have some chromosomal defects that can lead us to have an
infertility.
Instead of having X, we can end up having
XXX.
We can end up having 3 X's.
Superwoman.
X. What we call?
A superwoman.
A superwoman.
Extremely fertile?
Extremely.
Yes.
It is the assumption that they ideally should appear extremely more fertile, but funny enough is the more the X is still, we can actually end up having infertility.
Sure.
That's true.
Yes, then you can also have Turner syndrome,
Yeah.
where you have a deletion of one of the X chromosomes.
Yeah.
Yes. Then we can also have some ladies with an extra Y chromosome that still gives them the hyperandrogenic features. That is whereby she's a lady, yes, but you have some features, some male features because of this extra Y chromosome that can actually lead to features of virilization. Virilization, I mean, she's a lady, yes, all the organs seem to be female, but when you look at her deeper, you have some features of
male.
Yeah, unapata anaweza kuwa na mandevu.
Yeah.
I don't want to touch on that because mandevu can also can also mean another syndrome that comes later in life. But unaweza pata genital organs, they're not properly developed.
Yeah.
Down there, some organs are slightly bigger.
Yeah. Like the clitoris.
Yes,
now.
the clitoris when it's so enlarged.
Yeah.
Because usually say it's the male equivalent of the phallus.
Yeah.
So when it gets so big, it means niseme in literal terms, mwili likime changanyikiwa at some point, whether you need to be a male or female. So generally, when you see these hyperandrogenic features in males, it can be an early sign that you could be having a problem.
Yeah, sure.
Deep voice,
masculine,
masculinity,
and
clitomegaly.
I think also the hair. The hair of the lady are normally a bit. The hair distribution.
Yes. Generally, when you see the masculine features, it can raise suspicions of doing further tests really to confirm whether we have infertility or not. We've talked about the embryological ones, though later in life also we have an hormonal imbalance problem that is so common, by the way, that might have you these androgenic features. Mama ndevu. That is why I was saying, don't equate it directly that ukiona kona mandevu, it simply means that she's infertile. No.
But it's a risk factor. It's a risk factor.
It is an early, let me not call it a risk factor. It is an early telling sign that can make us suspect that you might be having something.
PCOS, right?
So we have PCOS that usually comes in the adolescent age. Now inaingianga from 18, 19, 20s. It starts at those ages. Mtu ako tu sawa all the way from early childhood. The genital organs iko sawa, kila kitu iko sawa. But when she reaches 18, 19, 20, what we call polycystic ovarian syndrome. Pia anaweza kuwa na hizi androgenic features. Androgenic, I mean the masculine features. Ndevu imeanza kuja. They have trouble with their menses. So, just to make it clear, PCOS is not equal to infertility.
Sure.
But PCOS has a 40% chance of infertility. I've seen ladies with PCOS when you're wamezaa. But the message is they will have trouble conceiving. But it doesn't mean PCOS is infertility.
Yeah,
no.
But I think
PCOS is a risk factor of infertility.
Yeah, sure.
Say it has a 40%
like,
chance
for example, if you know somebody who has a PCOS, it's normally advisable that they get pregnant earlier in life as compared to when they wait. When they get to their 30s, 35, it's normally very difficult for them to get this pregnant. But as we go to...
And that's what something. The good thing with PCOS is it's actually manageable.
Yeah, sure.
When you visit your guy and you make this diagnosis early, there are drugs that can actually control these androgenic features. There are drugs that you can actually add even to stimulate your ovaries more, and you can have a natural, a viable pregnancy.
Yeah.
It's only that you need to realize this early enough. This make your gyne your friend, make your gynecologist your friend. Now, it can be controlled really. I've seen people with PCOS with 2, 3 kids.
Yeah. Even me, I've seen quite a number of people with PCOS who have gotten pregnant and they're having. So as we move to our first break, I think when we come back, we will be talking about maybe secondary causes of infertility, and also some of the tests which you can do, and treatment options which are available here. And if you're joining us for the first time, this is Afya Yetu TV show, which normally tackles matters health, or more so sexual and reproductive health. And you can also reach out to us through all our media platform, and you can send us a direct message through 0110 100 258. Thank you, and see you after the break.
Eaglemount Academy is a private Christian-based institution located in White House Estate along the Nakuru-Solai Road in Nakuru County. We believe in prayer, smart work, discipline, and excellence. We mentor, nurture, and transform our learners into responsible young people in the community. In Eaglemount Academy, we offer education on a holistic level from daycare, ECE, lower primary, upper primary, up to junior secondary. The teachers are highly qualified and competent and give the parental love needed to the learners. In Eaglemount Academy, we offer computer classes and also integrate ICT in our learning in order to cope with the modern day technology. We offer French as a foreign language in order to help our learners link with other learners across the globe. We have invested in co-curricular activities in order to help our learners to be physically and mentally fit. We offer a variety of sporting activities such as football, volleyball, netball, swimming, and chess. We have club activities such as scouting, music and drama, wildlife, guidance and counseling, and 4K, which offer the learners with an opportunity to think critically and gain necessary skills for day-to-day living. Safety being our priority, our classes are spacious, well ventilated, and have adequate lighting. Nutrition being important for learning, we offer a highly nutritious, healthy, and balanced diet. Eagle Mount Academy, we are pride. Persistent, responsible, independent, dedicated to excellence. Our slogan is, we are the best. For more information, you can contact the office through 01 12 40 3750 or 07 43 94 8636, or email us on imacnax@gmail.com.
Are you a bishop, a pastor, or a church leader looking for a reliable, popular, and affordable TV station to air your sermons? Search no more. We have some good news for you. Tumaini TV is offering you the best package to broadcast your church services and sermons. Call us today and join us in bringing hope to the nations. Our lines are open. You can reach us on 0736 991 958 or 011 0100 258, or email us on info@tumainitv.co.ke. Tumaini TV, bringing hope to the nations.
Welcome back our viewers. I think today's topic imekuwa kubwa sana, na I think it's a very wide topic, a topic which we cannot exhaust with one day, and I think we'll have a part 2 of it. And as we welcome you back, know this is Afya Yetu TV program hosted by Nyaluk Foundation, and you can join us through all our social media platform, which is Tumaini TV. And you can send us a direct text through 0110 100 258, and we'll be able to sample your questions right here. And also, maybe if you want to be part of this show, kindly you can reach us through that number, and we'll host you here. And maybe before we tackle some few questions, I want maybe Alan to tell us some of the investigations yenye inaweza fanywa kwa hao watu wenye wanashuku ama wamekuwa confirmed wako na issues with fertility.
Okay, so I will tackle the female aspect. So for the female aspect, when you're doing investigations, one, we want to check how the ovaries are. Okay, let me start with the axis, the hypothalamo-pituitary and the gonad aspect. So we'd want to check what is in the brain, so that we confirm that the hypothalamus and the pituitary are all okay. So there will be investigations such as scans, such as head CT scan, where you can visualize these organs, the hypothalamus and the pituitary, to check whether there is any problem, like the way Daktari said, a tumor, any surrounding tumors, any infection that may present. And then we can also do hormonal tests, where we test the hormonal component that is in the blood. So we'll check for the gonadotropin releasing hormones, the gonadotropins in the blood, and other hormones that are surrounding fertility, that is the estrogen and the progesterone hormones, most of the estrogen, but also the progesterone is also tested. Then we can go down to the ovaries, so where we can do an ultrasound scan of the ovary. For the case of issues such as PCOS, where it can be visualized, the ovarian has cysts or are around it, so we can we can go down to it, water down to the ovary, check any problem with the ovary, be it the PCOS, anything that is impeding the release of the ova, and then we go down towards the fallopian ducts, where we check if there's any obstruction. So other things that may cause infertility is obstruction of this pathway towards the fallopian ducts, because the male sperms, they travel and fertilization happens in the fallopian tube. So what we visualize the fallopian tube to look if there's any barrier to sperms accessing the ovum, or the ovum coming from the ovaries, so that it can meet with the sperm. Then if we confirm there is nothing there, we can go down to the uterus. So in the uterus, there's an investigation for the uterus and the fallopian duct. There's an investigation called the hysterosalpingiography, which visualizes the whole uterus and the fallopian tubes using saline water and ultrasound. So it visualizes also the uterus. We see if there are any strictures, any polyps, any fibroids that as we had said before. So these are some of the tests that can be done apart from the hormonal assays and the CT scan of the brain.
And I think you've exhausted that, and you've done so well. Maybe Dr. Salvan, can you tell us maybe what are the treatment options, and is this thing covered with the insurances?
Asante sana Collins. I think Yalan has really covered it comprehensively, especially for the female factor. Amesahau wanaume wangu lakini yes,
boy child is always forgotten.
Is always neglected bana. Amesahau wanaume wangu. Though wanaume really, actually the first investigation that we usually do when a couple walks in with complaints of infertility is seminalisis. It's a very easy test. It's very fast. 10-15 minutes kuna results, and it tells us a lot. It has a lot of parameters. Hiyo ukifanya tutajua kama shida iko kwa mzee ama shida iko kwa mzee. Itatuambia ni sperms gani inatoka, what volume of sperms, what concentration of sperms, what is the pH of the sperms, what is the pH of the sperms. Itatuambia hizi sperms zinasonga ama zisongi. It's not just enough to produce sperms. Lazima zikuwe zinasonga zinapiga. Can they move after being released? Zinaweza songa ziende mali?
Double head, double tail.
Yes. Do they have flapping tails? What is the morphology of these sperms? Kuna zingine hadi ziona vichwa mbili, double heads. Yeah. There's nowhere they're going with those double heads. Kichwa ni mo? Kichwa inafaa kuwa moja. We have the head, the middle and the tail.
Two heads is better than one.
Ikikuja hapa kwa sperms kichwa ni
moja.
Kichwa ni moja. You have the head, you have the middle portion that iko na mitochondria nini. Then you have the tail that should be actively flapping.
Yes.
Inafaa tuambie the motility. Then inafaa tuambie the total content. Kumbuka sperms iko na semen. Actually semen comprises a greater portion. The ejaculate. Yeah. More than even the sperms. So for males, when you do that seminalisis, it gives us a whole picture of what should be expected. Due to time, I'll delve into it in our next topic on Jama nafaa toe sperm amount gani. Na that volume of sperm. Okay, it's 1.5 ml of at least 1.5 ml. 1.5 ml ni kwa wale wanasumbua wazee 1.5 ml. Unaona ile to drop tunapeana ya kunaweza na tunapeanga za drop. Per drop is 2 ml.
Yeah.
The to drop according to medical standards, imagine it's just enough.
Yeah.
Okay, but within that drop, at least per ml you should be having 15 million sperms.
Yes.
Per ml. So 15 meaning within the total ejaculate, 15 by 1.5 roughly, you should be having 30 to 40 million sperms per ejaculate.
Yeah.
pH at least inafaa kuwa more than 7.1, 7.2. It's slightly alkaline due to the secretions that come from the seminal vesicle and and the prostate. Then when it comes to kwa hizi sperm zote 39, the morphology, what percentage do you expect itakuwa sawa? It's actually at least 58%. That is why kuna mtu anasemanga men are very wasteful. Hizo milioni zote za, for us to say there's a problem, at least 58% ziko sawa. Hata kama kuna two double heads mahali, kuna tengine hatuna two tail, at least 58% should be okay. It comes to motility, what percentage inafaa kuwa at least inasonga. Azitapiga hizo milioni zote when you look them under microscope, but at least more than 32% should be moving, actively motile. So ukiangalia pale kwa microscope zinacheza pale vibaya sana. I think those are the key aspects that can help us determine male fertility. And another thing which is important, mtu anaweza toa ejaculate lakini haina sperms. What we call aspermia.
Aspermia.
That is now aspermia. Yes.
Oligo is few.
Yeah, oligo is few.
Okay.
That is what actually oligo, we define oligo by these values that nimepeana. 15 million per ml. When it's less than that, we say we have oligospermia. But when ikikuja to adi less than 5 million now we have severe oligospermia. And the treatment options now will depend on how severe do we have our oligospermia. Kama iko lakini tunaweza, so can we enhance? What can we do? Ni mtu tunaweza pea chance ya ama tunaweza kutolea tuweke ndani. What we call intrauterine insemination. But ikiwa kidogo sana inabidi tuziharvest. What we call testicular sperm extraction. Or testicular sperm aspiration. So aspiration is literally, actually I've started answering your question, nimeenda pale kwa how we can treat this. Aspiration ni tumechukua syringe literally pale kwa testis. Tunaingia ndani. We extract your sperms.
I think maybe I was thinking because of time we can maybe take some few questions, then we'll dwell on it on next time, because it's a very wide topic.
It's a very wide topic.
And it's something which affects millions. Because I think right now we have so many people who are having this condition.
Actually more than the global burden of infertility, according to WHO, we are at more than 30% globally.
30% of the total population.
Not of the total, of the childbearing population.
Of the childbearing population, yes. So it's a big issue. And I think we need more time to expound on it. Maybe from the treatment option and as such. So maybe
that is very true, Collins. Just to add something finally on seminalysis. Wazee, seminalysis is a first process. It's a ni kitu unaweza fanyiwa kama umekaa hapo na utoke. You can just walk into these labs, wape sperm sample yako, pima tu saa zingine uone mambo iko aje. I know I know it's not an easy thing to do, because kuna watu wanasema utapata chenye unatafuta, but unaweza enda tu uangalie tu uone mambo yangu iko aje, especially for those of you wenye hawajaingia kwa ndoa. You should be there as the labs guy should put it as a, what can we call it, marriage package. Siku hizi naona kuna wellness package, honeymoon package, marriage package or dating package, wherever.
So umesema unaweza kuwa unatembea tu but you shoot blanks.
Mbaya sana, una shoot ma double head. Mbaya sana.
So there are some couple of questions which have been sent here, but I know Nini, from what I've seen, some of them we've answered. I think most of them we've answered. But I'll just take the first one. There's somebody who has asked that. I think this one has been answered. What shows or how can you know that you are infertile naturally? I think that one we've answered. And does the age impact the fertility? That one we've answered. And there's this one about the... I think these are myths, and I've read about it also, that maybe if you've been having multiple sexual partners, or you've been having like a sexual partner for a certain duration, then you broke up, then you get a baby with another person, can you have the DNA of your ex? I think Alano maybe can give us his view as we end, and maybe Dr. Salvan also will add something on top of it.
Okay, so biologically, once you're born, there's that genetic structure that you have, yeah? And what changes the genetic structure is mutation of your DNA. Nothing else can come in and change your genetic structure. So what I'm thinking, yeah, is you cannot actively take someone's DNA unless now in the aspect of fertilization where half of the man's DNA and half of the female's DNA conjoin and form one. So for this child to be born, it requires the genetic structure of the female and the genetic structure of the male. So when it comes together, that forms, a mix of their two DNAs. So you can't say that there's someone else's DNA that is gonna come in. And then already your ova, according to the genetic structure you're born with, already your ova carries your half of your genetic characteristics, as we both know. The X, the female gives the X. The male gives the Y, right? Yeah. So half, both the X and the Y, the male gives both the X and the Y. So half is already preformed because you are born like that. It cannot be changed by someone else. So according to me, it's a myth, but maybe it should be researched, looked into, but I doubt, because already your genetic, it doesn't change. It's the way it is unless there's mutations in your DNA. So once they come, it's just half the DNA that is consistent with yours and half the DNA consistent with the male. So I think I've answered from my point of view.
Do you have something to add on?
No, not really much. I think Alan has expounded on that.
Okay.
Well enough.
Then maybe.
Yeah. I think there are a lot of scientific researches on what is it called? Yeah, what is called microchimerism.
Yeah.
And that is transfer of DNA from the mother to the fetus. That happens. That is possible. But from a male to another, and the woman retaining that DNA when they move to their next sexual partner. Actually, there's a term for it. What is it called? Yeah, there's a lot of research around it, but really we have nothing conclusive that is scientifically backed.
Because, from what I know about genetics is that maybe if you have a genetical defect, something which is interfering with your DNA, which is a bit, I would call it passive. It can get into your DNA passively, but it won't affect people of your generation. It will affect people of maybe the 4th, 5th generation in your lineage. For example, when they are vaccinating things like cows and they're interfering with their DNA as people perceive. So that the drug which interfering with the DNA of that maybe cow, and you go and take that meat, it won't affect you directly. It will affect people down your lineage. That's what normally happens. And last but not least, there's a question here by somebody called Richard. Anauliza ati if a woman have 2 reproductive systems, can all of them be fertile, and can the person conceive at the same time with these 2 reproductive organs? And I don't know, maybe Salvan, you can take it as we wind up.
The question is an interesting one. I'm trying to think that whoever asked that question maybe is thinking that is one of the way we get twins or something. Okay. Really, no. It's a funny question, really, and an educative one at the same process. Really, you can only work with one reproductive outflow tract. There are very many high chances of infertility or having a problem really with the
sexual intercourse,
with the delivery, with
pregnancy, carrying the
fertility,
pregnancy.
generally the whole reproductive health cycle. We might have some serious problems with it rising from that, because at the end of the day, it's only one that can be fully functional, and the other one is literally occupying unnecessary space.
Yeah.
So I think what they do is they usually block the faulty one, and
yeah.
we try to enhance the one one that is more patent, the one that is more functional. Yes.
Like there's a case where I think I was in my first year or second year where we got a baby, a female, not a female, a male child who had two penile shaft at birth. Then I was discussing it with somebody, and the person I was discussing it with a lady, and she was so excited that maybe now if one is not functioning, he can use another one, and the other one, which is not normally the case. What's normally done, we do a medical assessment, and after a medical assessment, we look at the I would call it an organ, the penile shaft, which is more potent, and the one which is less potent is normally we do a surgery and we remain with one because you cannot have two. Yeah, maybe Alano can have his closing remarks.
Okay, I from your case, yeah, that's true, and Dr. has answered. I don't think you can have two very functional ones. There's almost 90% chance that the other organ is almost non-functional. Yeah. It's just there. So what they do, again, surgical correction, and they enhance the one that is potent.
Yeah, as we close our show, I want to take this opportunity to thank you, our viewers, for joining us in this conversation. And as Dr. has said, that we have so many people who have this condition, and this topic is so wide, we cannot finish it in one sitting. So join us again next week, same time, same place, where we'll be dwelling into matters management and other tests which can be done, and maybe treatment options, and where you can go and get these services. So as we end the show, thank you so much. This is Afya Yetu TV program sponsored by Nyaluk Foundation. Nyaluk Foundation is a local NGO which is located at Nasha Plaza, first floor, and we do mostly we deal with the sexual and reproductive health, mental health, and environment and health. See you again next time. Thank you so much.